Good evening, everyone. Welcome to the presentation. My topic is management of vitreous hemorrhage in an already lasered proliferative diabetic retinopathy. Moderator is Dr. BJP sir. The presentation is divided into introduction, pathophysiology, management of vitreous hemorrhage, anti-VEGF related studies, and summary. A bit of historical trivia. Non-resolving diabetic vitreous hemorrhage was the indication for the first pars plana vitrectomy done by Robert McKimmer in 1970. The landmark DRS study, diabetic retinopathy study, identified four high-risk characteristics which are associated with severe vision loss. Severe vision loss is defined as less than 5 by 200 vision at two separate occasions 4 months apart. These characteristics were vitreous hemorrhage, presence of new vessels on the disc, and severity of the new vessels. Three or more of these characteristics will be termed as high-risk PDR. In the DRS report number 3, they noted that if NV is present along with vitreous hemorrhage, the risk of severe vision loss is 29.7%, while the same for NVD is 25.6%. Also, vitreous hemorrhage and tractional retinal detachment involving the macula are two of the most important surgical indications for surgical intervention in PDR. So, how do the vitreous hemorrhage occur? In order to understand this natural course of the PDR has to be understood. A brief of this. Uh, Progressive retinal ischemia leads to release of pro-angiogenic factors. Along with that, there is VEGF, including that is VEGF. This leads to formation of new vessel buds along and fibrous and glial tissue which grow along with the new vessels. These vessels grow along the posterior hyaloid layer, posterior hyaloid surface. In this image, we can see a new vessels elsewhere, which is growing along the posterior hyaloid surface with some intragel hemorrhage, which has occurred spontaneously. This is a OCT scan of a NVD with posterior thick hyaloid, some traction and involvement of the, and inclusion of the NVD within the posterior hyaloid surface. As a side note, the types of vitreous hemorrhage based on the location of the vitreous. So there is intragel, which is the slowest to resolve and clots early and changes in color. Subhyaloid, which is fastest, and subalum bleed. So conventional pan-retinal photocoagulation. The ICO updated guidelines have determined the number of burns, the density of the burns, the extent that is to be given in order to the total number of burns that they are advised is about 1200 to 3000. 500 micron is the spot size with 1 degree, one burn apart between the two burns. However, they also recognize that you have to titrate the treatment based on the severity of the PDR. That means that in a severe PDR, we can also go to as a 0.5 to 0.75 burn width apart. How does the pan-retinal photocoagulation work? As we know, RP and the outer receptors, RP and the photoreceptors are the most oxygen-consuming tissue in the body. This image on the right side shows a burn, retinal burn in a retina, which shows destruction of the RPs as well as the photoreceptors. So, because of this destruction, there is a reduced oxygen demand that we are creating within the retina. Also, diabetic retinopathy is an inner retinal disease. With the choroidal oxygen, because of the destruction of the RPs and the photoreceptors, the choroidal oxygen reaches now towards the inner retina, and the oxygen, um, so that the hypoxia which is in the inner retina is relieved. Also, some studies have shown that pan-retinal photocoagulation increase the vascular density, vessel density in the macula. The DRS study shows that PRP leads to reduction of 50% in the severe risk of severe vision loss in a high-risk PDR group. Also, the ETDRS study shows PRP leads to reduction of 50% in the progression of PDR, and Indian retinal disease study group showed that PRP reduces the possibility of vitrectomy over a 10-year period. So how does vitreous hemorrhage occur after a pan-retinal photocoagulation? Vitreous hemorrhage causes severe vision loss in around 52% of patients. This was the finding of a post-PRP patients in ETDR study. Other studies found the incidence to be around 32%, 37, and 39 within a follow-up of around 1 to 2 years. So we can group the vitreous hemorrhage which is occurring after a PRP into immediate and delayed. Causes of immediate vitreous hemorrhage are regression of the new vessels causing traction of the friable new vessels. Also, the PRP takes time to effect, so there are still development of the new vessels which can lead to bleeding. Also, PRP has shown to lead to increase in PVD. So the extension of the PVD can cause a traction over the new vessels. Another is incomplete or inadequate PRP and new vessel formation, which is progression of the PRP, PDR. So DRS report number 13 has shown that higher treatment density of PRP was associated with reduced risk of severe vision loss. There are various studies which have studied the progression of PDR after PRP. They have found that poor systemic control was one most important risk factor leading to progression. This includes baseline low visual acuity, diabetic nephropathy, hypercholesteremia, among other things. Also, there has been found to be a relationship between PVD induction, PVD, and PDR severity. So, one study found only 3% of patients developed new vessels in complete PVD patients. Another is study found that complete PVD is protective against PDR progression. A study found by Chu et al. Said that incomplete PVD leads to 5 times increase in sight-threatening diabetic retinopathy. Also, 0% of complete PVD with collapse developed diabetic retinopathy progression. As we know, as we have seen, PRP leads to extension of the PVD. So this PVD was extension was seen in around 50% of patients after PRP, and this was irrespective of the severity of the disease as well as the presence or absence of vitreous hemorrhage. The end stage of diabetic retinopathy is a quiescent, burnt out, or involutional PDR. This is characterized by complete vitreous detachment, except at areas where retinal vessels or fibrovascular tissue is attached. There is reduction in the caliber of the vessels, fibrous component increase, and tractional detachment and vitreous hemorrhage are seen. This may or may not involve the macula, and if macula is involved, then a severe visual loss can occur. PRP is entity which quickens the development of involutional PDR without the side effects of, without the adverse events of tractional detachment and vitreous hemorrhage. So how do we manage the vitreous hemorrhage in an already lasered PDR? I've divided it into first is examination, investigations, and treatment of the. I will illustrate that with basis on cases. So this was case one is a 35-year-old female which is diabetic since 17 years, along with other comorbidities like asthma, hypertension, and liver disorders. First visit was on 5th of October. She had complaints of diminution of vision in the both eyes since last 2 months. On examination, there were NVs seen in both eyes, along with OCT finding of diabetic macular edema in both eyes. So, both eyes PDR with macular edema was diagnosed, and she was advised to undergo PRP 3 sittings both eyes, and anti-VEGF injection was given in both eyes. Her next visit was 1 month later. She developed progression or worsening of the vision in the right eye to 2/60, while left eye improved in vision. So this is the fundus photograph outdoors image in the right eye at the first follow-up visit. This shows vitreous hemorrhage. Along with that, the edema had not resolved in the right eye, but edema had resolved in the left eye, which explains the increase in visual acuity in the left eye. The OCT scan crossing the disc shows a new vessel, NVD, with some mild element of traction, while it's normal in the left eye. So left eye fill-in PRP was advised, and in the right eye, anti-VEGF for the macular edema was advised, and observation for a period of 1 month was advised. The third visit, the vitreous hemorrhage had increased, and OCT imaging was not possible. So BIS scan was done, and you can see a highly reflective clump echoes were seen at the disc, suggestive of FVP, and subhaloid hemorrhage, subhaloid heme was also seen. The retina was attached throughout. Also, at the same time, in the second follow-up, the left eye developed edema. So, fill-in therapy was anti-VEGF injection was given in the left eye, while in the right eye, anti-VEGF as a preoperative adjunct and followed by VIT MPEL SOI was advised. So, the diabetic retinopathy vitrectomy study. This study has been guiding us in order to, with the, in order to determine the period of observation after a vitreous hemorrhage in PDA. So, this compared early with deferred vitrectomy for 1 year in a severe vitreous hemorrhage with PDA. The results were that in type 1 diabetes mellitus, early vitrectomy was associated with 25% and in deferral, 15% of patients showed better visual than 2 by 40 at 2 years follow-up. However, only 20% of cases, complete resolution of the vitreous hemorrhage was noted. But this study was done in a period where surgical advancement was not great. So we did not have a wider field of view. The endophotocoagulation was not was poor. So in the same settings, multiple studies have found a better visual outcome for early vitrectomy. On vitrectomy's results have been better than what DRVS has told us. So, what two factors to consider in order to advise an observation? So, ultrasound findings. We know tractional element should be present in an ultrasound. If the view permits, the OCT can be done. Anti-segment evaluation with in order to rule out neovascular glaucoma should be done. We have to take into consideration the occupation of the patient, whether he needs his vision in an early period. So we can also guide our decision based on what the patient wants. The time of PRP prior to vitreous hemorrhage, systemic control, a compliance to follow up. So whether we have a good compliance or not, and whether patient is able to uh, follow our guidelines has to be taken into consideration. The current recommendation is in a first first vitreous hemorrhage episode, an observation period of 4 weeks is given in a eye with no tractional element. This case scenario number 2, this is of a 60-year-old male who complained of floaters in the left eye for 1 year. Diabetes mellitus was present since 15 years and hypertensive since 1 year. In 9th of August, he was diagnosed elsewhere as right eye NPDR and left eye PDR. Left eye 3 sittings of PRP were done. He came to our OPD on 28th of December uh, with the visual acuity in the right eye of 6 by 6 and in the left eye 6 by 7.5. We did, and in the left eye we found vitreous hemorrhage, but it was not obscuring his vision. In the right eye on FFA, there were multiple leakages seen, so we found that the eye was not NPDR but rather a PDR. In this setting, both eyes PRP 3 settings were advised, and fill in PRP was advised in the left eye, and observation was advised for the left eye. Another scenario where a diabetic and hypertensive with 14 years, since 14 years, a 55-year-old female was diagnosed as PDR with PDR in both eyes with left eye vitreous hemorrhage. Both eyes PRP was done in October 22nd, and he came to our OPD with a history of left eye vision loss since 1 month because of vitreous hemorrhage. On ultrasound, and the left eye showed again hyperreflective clump echo at the disc, a hyperreflective membrane with variable echogenicity and sub which suggestive of IPVD, and we know that multiple dot echoes were seen suggestive of subhaloid hemorrhage. So this patient was advised directly an elective surgery of phaco-IL with MPEL under on the same visit. This is the post-op image of the patient. The next scenario is of a 50-year-old male with diabetic since 10 years. HbA1c is 12.5, uncontrolled hyperglycemia, who whose complaints of diminution of vision and floaters since 2 months. Was diagnosed as both as PDR and left eye DME. Underwent PAP elsewhere. So this is the fundus photo at the photos image at the time of presentation to our institute. So we can see intragel hemorrhages in the both eyes. Along with that, in the OCT, both the eyes showed a flat foveal contour with some hyperreflective dots suggestive of uh, exudates. In the right eye, a center involving cyst was seen at the superotemporal quadrant in the left eye. A tractional element was seen with uh, detachment of the tractional detachment of the retina. Both eyes PRP were advised, and in the left eye, PRP was to be done one disc away from the TRD. Right eye, Razumab was given for the center revolving DME. Next follow-up, left eye was vitreous hemorrhage was seen, and the BCV vision has reduced to 2 by 60. This image of both eyes OCT was done. The right eye, the cyst which was present in the earlier period had reduced, but the traction which was present at first in the superior temporal quadrant has increased and reached to the foveal element in the left eye. This is the vertical scan showing tractional detachment of the retina involving the macula. So right eye observation was advised, and left eye was advised to undergo surgery for with a prior anti-VEGF injection. At the time of glass appointment, the vision has improved in the right eye to 6 by 9, in the left eye the vision was 6 by 24. So the indication for surgical intervention in VR after PRP are non-resolving vitreous hemorrhage, a dense premacular vitreous hemorrhage, vitreous with traction involving the fovea, recurrent vitreous hemorrhage, and also patient's decision. So anti-VEGF, this has been studied extensively in order to vitreous hemorrhage cases. It has an established role as an adjunct prior to vitrectomy to reduce the intraoperative bleeding and reduce operative time. Various studies have been done in order to determine the role of anti-VEGF in vitreous hemorrhage after a pan-retinal photocoagulation. These studies show that vitreous hemorrhage clearing, a better visual acuity, reduction in recurrence rate, as well as uh, uh, decrease in tractional detachment or recurrent bleeding were seen as compared to other treatment modalities in these studies. DRCR.net protocol AB, this compared intravitreal aflibercept versus vitrectomy plus PRP in VH after PDR. In the sample size, PRP 2 months prior from the baseline was also included in the trial. So, in the study, no difference was found between the two intervention arm in terms of the BCVA. However, a 33% crossover was seen. That means aflibercept group did underwent some cases that did get PRP, while vitrectomy plus PRP did some cases had to be given aflibercept. Is there a preventive role for anti-VEGF in VH post PRP? So the one study by Lim JV et al. They studied 12 eyes with prophylactic bevacizumab after PRP. The interval between intravitreal bevacizumab and the first recurrence of vitreous hemorrhage was noted, and it was found to be around 3 to 4 months. And thereafter, they gave intravitreous IVB injections prior to the expected recurrence of vitreous hemorrhage. And this protocol, none of the eyes or the patient developed a vitreous hemorrhage recurrence. Clarity study compared aflibercept versus PRP in PDR. Around 40% of the sample size had previous PRP treatment at the time of randomization. The study found reduced rate of VH and decreased probability of need for vitrectomy in aflibercept group. Zhang W et al. Made a meta-analysis of this combination treatment of PRP with anti-VEGF versus PRP alone. Multiple studies like Proteus, Restore, Reveal, et al. And others were included in this meta-analysis. They found that the combination therapy to be superior to PRP alone in terms of best corrected visual acuity, new rehearsal regression, CMT values, DME incidence as a surgical adjunct, as well as adverse events which included vitreous hemorrhage. So, in order to illustrate this, use of anti-VEGF in a vitreous hemorrhage case, this case scenario of a 57-year-old male, diabetic of 10 years and hypertensive since 5 years, came on 16th of March and presented with right eye 3 by 60 vision, while left eye 6 by 9. Both eyes were had diagnosed as PDR. Right eye had already underwent surgical intervention elsewhere, while the left eye had has received the PRP 1.5 years back. Both eyes had also been given anti-VEGF injection in the past. So this is the optos image and OCT of the scan of the patient. at the time of first presentation. As you can see, some vitreous hemorrhage in the left eye was seen, as well as in the left eye, center involving cystic spaces were seen at the fovea. So left eye fill-in PRP was advised, followed by anti-VEGF injection for the center involving uh, DME in the left eye. Next follow-up was 1 month later. The right eye vision was similar, while the left eye had improved to 6/9. Again, presence of center involving DME was still there, and so anti-VEGF injection was repeated. Next follow-up was in May, and the left eye was observed because the center involving DME had reduced. However, the patient was lost to follow-up and came on 28th of December after 4 months with presenting with best corrected visual acuity in the left eye of 6/60. In the B scan, there was subhyaloid heme was seen, retina was attached, and clump echoes were noted inferiorly. Again, this was like a first episode, and this presentation of diminution of vision was around 10 days, so observation was advised. This leads us to the concerns with anti-VEGF use. A pooled data from drcr.net found that a 1 year cumulative probability of TRD was 6.8 in control groups, while 4.8% in anti-VEGF group. They stated that these findings do not support the hypothesis that anti-VEGF increase the risk of TRD among eyes with PDR. However, the TRD that develop after an anti-VEGF is a faster process. So that develops within 3 to 31 days, a mean of 31 days, 13 days after injection. While others noted it to be 1.5 to 2 months. There is a term called Crunch syndrome, anti-VEGF related Crunch syndrome. So this is a vision loss of 1 to 6 weeks post injection because of new or developing traction detachment progression. This was seen mostly with bevacizumab injection. Also, with anti-VEGF use, a regular follow-up is necessary, and so loss of follow-up was high. It was around 33% in the pooled data by drcr.net. This loss to follow-up was because of many reasons. More among them were distance from multiple visits, distance from from the hospital, as well as patient non-satisfaction with the treatment. In certain comorbidities, anti-VEGF injection cannot be given, like a recent myocardial infarction, a thromboembolic disorder, and other stroke and other conditions. However, considering the evidence, a recent shift in management approach for in proliferative diabetic retinopathy has been considering the role of anti-VEGF therapy. So the current recommendation for anti-VEGF in post-PRP PDR includes a prior to surgical intervention, reducing the intraoperative bleeding and the operative time. In vitreous hemorrhage with associated non-tractional DME detected on OCT, anti-VEGF can also be given in a patient with good compliance to follow up. A dense vitreous hemorrhage that precludes PRP and no tractional on ultrasound is seen. Anti-VEGF can be tried. However, the patient has to be on a close follow-up, like around 1 to 2 weeks. And PRP should be done as soon as the fundus view becomes clear. In an NVG case with NVI, also anti-VEGF use has been seen, but aggressive PRP is the treatment of choice in this case. With anti-VEGF use, a good follow-up is necessary in all cases. So to summarize, in cases of early vitreous hemorrhage without any traction, observation for 1 month is advisable to look for resolution. In case of some view of the fundus, a fill-in PRP can be done. If it is not cleared by 1 month, then a surgery is given for the non-resolving vitreous hemorrhage. Anti-VEGF use can be used as an adjunct in the preoperative period to reduce intraoperative bleeding time. In dense vitreous hemorrhage, anti-VEGF can be tried if follow-up compliance is assured and no traction is seen in ultrasound. A combination use of anti-VEGF and PRP can be the treatment used to prevent a post-laser vitreous hemorrhage. Thank you.
Thank you, Harshal. So you can go back to the summary slide. So yeah, so vitreous hemorrhage without traction we can observe. Okay, this is in a setting post PRP vitreous hemorrhage. That's a situation which has been given, and whatever views there, you try to do laser. Okay, so vitreous hemorrhage can clear over time, and as the hemorrhage clears, you add more laser. Okay, so the vision can improve, and patient may not need a surgery. But if the vitreous hemorrhage is not resolving from more than 1 month, then it may not resolve over time. So the patient may need a surgery. There are some indications when the patient may need an early surgery, like a one-eyed patient or the other eye is not doing well or something like that. You can offer early surgery also. Anti-VEGF can be given, but you should be sure that there is no traction. Okay, but if there is traction, there is a risk of Crunch syndrome and worsening of the tractional retinal detachment. Yes, if you have decided on surgery and if you know that the PRP which has been done is not adequate, and you think that there may be a lot of florid new vessels, you can give anti-VEGF preoperatively. Thank you.
So very good summarization of the use of anti-VEGF and the management of vitreous hemorrhage. But tell me, how does the management differ whether the patient has a prior PRP or if there is no laser done?
Ma'am, some authors have said that a longer follow-up period after a PRP can be considered because PRP takes time to take its effect. So some authors of around 3 to 4 months are also given this as a follow-up period following a post PRP vitreous hemorrhage.
So you mean to say if the patient has developed vitreous hemorrhage in a lasered PDR, you would wait longer for the hemorrhage to...
Yes, ma'am. Some of the authors have this consensus, but it's not generally recommended.
Okay. If there is a vitreous hemorrhage which is blocking the vision and sight threatening,
Yes,
then the management will be the same
same
whether
as
the patient has the laser done or not laser done.
yes, ma'am.
Only thing is obviously the laser gives more protective benefits to the retina. So you would expect less complications in a patient who has already had laser.
Yes,
So you would expect the retina to be good and no TRD, or even if you end up with some complications during surgery, you still have a lasered area of the retina which will remain safe, remain protected. It will not cause bad RD, etc. will not occur. So that is the advantage of having PDR. But the management of the vitreous hemorrhage does not depend on that. Whether the patient has PDR, whether the patient has had PRP or no PRP, it would probably you would take the same decisions and do the surgery if needed. And as far as the use of anti-VEGF is concerned, uh, obviously it can be used as an adjunct to PRP in very few select cases, not in the cases where the type of cases that we see where there is already fibrovascular prolif, already some amount of retina shows some traction. So those cases obviously you cannot use anti-VEGF as a adjunct. But very few cases where there is just starting of NVD or NVE with no fibrous element, you can use the anti-VEGF as a adjunct to PRP. And another situation where you can use it to prevent vitreous hemorrhage is actually post-operatively. So when you have a patient comes with attacks of recurrent vitreous hemorrhage after vitrectomy, in those situations an anti-VEGF can be definitely beneficial. So instead of doing repeated surgeries or vitreous lavage, you can give an anti-VEGF which will help in clearance of the vitreous hemorrhage and also prevent further recurrences.
Nice and elaborate presentation, and I'm glad you made the summary because that puts things in perspective. But probably one thing that is not mentioned is, we have our patients, we've been following them for years. So the fundus drawing, which will tell you where the proliferation was, because if an adequate PRP was done, somewhere, sometimes down the line, the patient suddenly comes with vitreous hemorrhage, and you've been following that patient for years. You know the PRP was adequate, but if you see that there was some persistent fibrous proliferation or something, then and the bleeds are recurrent, they come, they clear, they go, they come, they clear, they go, then that is a situation that eventually you may need to do surgery because probably there's traction from some blood vessel that keeps happening and bothering the patient now and then. So it's a good idea to go back at the patient records, see what documentation was done. If there's absolutely no proliferative tissue there, it could be just a PVD that has occurred. If there was a lattice in the periphery, it could be an avulsed vessel from the lattice. So I think when we look at bleed post PRP, it's a good idea to have a look. See, now everybody takes an optos image. Go back to the optos image and see what happened. Because anti-VEGF gives you a very, it's a very dicey kind of happiness that you get for a temporary period if you don't really look at why the eye has bled. So I think it's a good idea to go back to your previous documentation. How much laser was done? Did we say avoid laser because of fibrous tissue? So laser was not complete. All these things will tell you whether you really need to have surgery or not. So I think that would be, I would say, point one. Look
Yes.
at previous records, because you've already decided that this particular class is for not treatment naive eyes, patients who have had
Had it.
laser. So your first point under summary was look at the record and check what was done, what was the fundus finding, and then you make your plans from there.
Yes.
One other thing is that the anti-VEGF does not clear the vitreous hemorrhage. Anti-VEGF just regresses the new vessels and prevents rebleeding. So a lot of time the patients have rebleeds, and that's why the vitreous hemorrhage does not clear. So the vitreous hemorrhage clears spontaneously. When the anti-VEGF does not clear the vitreous hemorrhage, it only prevents rebleeding. So it gives again you only a short time frame for the vitreous hemorrhage results. Then probably you can add more.
I reiterate the point that Dr. MP Madam was making, that you have to look at the previous record. If a patient has come to you, then still you'll have to look at the records that he or she has with him or her, so that you can actually look at the progress of the disease. So recurrent vitreous hemorrhages, recurrent intragel vitreous hemorrhages, which you yourself have mentioned in your presentation, that take a longer time to resolve. So it's quite obvious that this is not going to go away. So there's no point waiting in such cases. Versus where the hyaloid has detached, it has caused a traction at its anchor, some fibrovascular prolif, and it has bled into the subhyaloid space. This kind of blood will eventually disappear.
Yes.
And if the macula is well attached on the ultrasound, there's likelihood that we can wait and watch. Versus where you have cases where you have done extensive what do you call PRP. There's hardly any space where you'll do any more PRP, but you see localized pockets of hemorrhage. You can just still observe, or maybe you want to wait for the hyaloid to detach some more, clear the posterior pole. Where there is hemorrhage which is stuck, like a vitreocysis, stuck, there is some hyaloid, subhyaloid hemorrhage, but there's intragel hemorrhage. The hyaloid is not separated completely. There's completely, filling up the posterior pole, but you can see everywhere else. And you have a lot of areas, skip areas. You can still do those areas. But when the razor is very adequate, you don't have anything else to do. You don't advise anti-VEGF, because that's not going to take care of that clotted blood. You can straight away advise surgery.
Yes.
Those are easier surgeries that can be done, performed easily. So the risk of breaks because of your own intervention is less. So it's everything with regards to what has happened previously, how much PRP was done, what is the state of the gel vitreous, how many new blood vessels were there. It's like an arc all around the thing, whether the macula was previously threatened because of that, because of the TRD. So those things you have to keep in mind. So post PRP, that is what we look into it, whether the PRP was adequate, whether new vessel disease has regressed, but this is more of a tractional hemorrhage, whether the hemorrhage is covering the posterior pole, whether the hyaloid is separated from the macula, whether the TRD has progressed under the vitreous hemorrhage. So these are things that you have to look at. Or if it is a one-eyed patient, that's the only seeing eye and has developed vitreous hemorrhage, I don't think there's no point. There's any point in waiting.
Early.
You need to go with an early surgery. But anti-VEGF is not a treatment of choice.
No, sir.
Just for vitreous hemorrhage, clearing vitreous hemorrhage.
Also, routine use of anti-VEGF prior to vitrectomy is also not advisable. So there are centers where routinely an anti-VEGF is given 3 to 5 days before, and then vitrectomy is done. So whether there is a need for the anti-VEGF, that is also not determined. So Anti-VEGF can be used if there is a vascular prolif which is going to bleed, which will definitely be benefited if you use anti-VEGF prior to the surgery. But if it's just a simple vitreous hemorrhage, then there is no need to use anti-VEGF prior to surgery. And sometimes if you don't know what is there inside, then this anti-VEGF can in fact cause that crunch and have difficulty. So a TRD which would have been easier to dissect will become difficult simply because of the use of anti-VEGF. So I think the routine use of preoperative anti-VEGF should not be encouraged.
Thank you, ma'am. Thank you.